My name is Rebecca Richards-Cordum. I am one of the co-directors of Rice 360, and on behalf of our institute and the program committee, I am so excited to welcome you to the Innovation for Healthcare Access Conference. And here to kick things off is Rice's provost, Professor Amy Dittmar. Amy?
All right, well, welcome. And I'm going to say this is Amy Dittmar, who forgot her reading glasses this morning, but luckily they give me very large font. So if I look like I'm squinting a little bit, apologies. So, well, good morning, everyone, and welcome. This is the inaugural Innovation for Healthcare Access from Global to Local Conference. And as you know, it is hosted by the Rice 360 Institute for Global Health and Technologies, which are led by Rice's pioneering bioengineers. You just saw Rebecca Richards-Cordum and Maria Oden, who is sitting here with us in the front. And as Rebecca just mentioned, I am Rice University's Provost and Executive Vice President, Amy Dittmar. So first, on behalf of the university, I am really honored to welcome you here today. You are the innovators, the clinicians, the community leaders, the researchers, the policymakers, and the students, all of you to this conference. And we need all of those people to make a difference. We are so grateful that you have joined us to explore the groundbreaking tools and approaches for addressing high priority, unmet healthcare needs in underserved and rural communities here in Texas, as well as throughout the United States, much as we've done around the world. At Rice, we are at a pivotal moment in our own history. We have a re-energized and renewed strategic plan, and through that, we are committed to being the world's premier teaching and research university, delivering unparalleled personalized education and propelling breakthrough discoveries to transform lives and improve humanity. This conference embodies our vision for the future by bringing together the individuals, both the implementers as well as the thought partners, to address the big challenges with even bigger solutions. We know that the challenges are incredibly complex. Innovative technologies exist, but too often, they don't reach the people and the places that need them the most. Bridging that gap requires more than invention. It requires collaboration that spans engineering, medicine, public health, and community engagement. It requires reimagining not just what we create, but how do we deliver it? And how do we sustain that over time? Together, we can learn from the experiences and insight gained from our global partnerships, that those offer lessons for tackling health disparities. I'm going to pause for a second and let everybody come in. So it's just a great group of students. All right, so together, we can learn from the experiences and insight gained from our global partnerships and offer lessons for tackling the health disparities right here in our own backyards. We can apply those lessons to improve outcomes for mothers and babies, advance the prevention and management of chronic disease, and strengthen health systems in underserved and in rural communities across Texas and beyond. Over the next 2 days, you'll hear from leaders who are redefining what is possible for improving maternal and newborn health and chronic disease prevention and care in our marginalized communities. And you will see innovative technologies meet remarkable partners and have opportunities to build connections that will lead to real, measurable impact. As we begin, I encourage you to go forward and think big, share openly, seek collaboration in unexpected places, The solutions we need will not come from any one discipline or any one organization. They will come from all of us, working together across sectors, across borders, across disciplines, guided by our shared commitment to health, equity, and access. Again, I want to thank you for the work you do, and I thank you for being part of this movement, for bringing your energy, your creativity, your expertise to this timely and important conversation. It is now my distinct honor to get to introduce our keynote speaker today. Dr. Wilburn Wren is a clinical associate professor in the Department of Obstetrics and Gynecology at UT Southwestern Medical Center, as well as the medical director of labor and delivery triage at Parkland Memorial Hospital. She specializes in obstetrics and benign gynecology, especially complex cesarean sections, tubal sterilizations, and obstetric care for the underserved. She is a member of the American College of Obstetricians and Gynecologists, and Dr. Wilburn Wren earned her medical degree at East Tennessee State University and completed her residency in obstetrics and gynecology at Howard University in Washington, D.C. We are so honored to have you here today, Dr. Wilburn Wren, and I welcome you to come up and speak with us today.
All righty. Good morning and welcome, everyone. So I'm standing here and I'm scrolling on my phone, not because I have an issue with TikTok, etc., but because I have a picture of my parents here to remind me of where I came from and a debt that I owe to a nurse who took care of me at birth. This is the true story of access and maternal care and neonatal outcome. I was born after my mom underwent preterm premature rupture of membranes with chorioamnionitis, and I was a small for gestational age baby, despite the fact of being premature. I was born at a point in time, which sort of lets you know what my age is. I was born at a point in time where there were no antibiotics, there were no steroids, there was actually no care for infants that weighed less than 1,500 grams. I fell somewhere at 1,400 grams and was given a prognosis of 0 chance for survival. There was a very special nurse who took care of me, fed me, spoiled me, and that is the only reason I am here today. So not only do I owe a debt to my parents, but I also owe a debt to whomever that nurse is, wherever he is. So thank you for that. All righty, so today I'm going to talk about deployment of a mobile health unit in an underserved area that extends postpartum care for a year. This was a huge undertaking. MCAP is a program that was sponsored by UT Southwestern and Parkland Hospital. We are developing this program in association with Dallas Healthy Start and Hope Supply Company to sort of address the social determinants of health and some of the social needs of our patients. We were able to undertake this program due to a charitable donation from the Heyman Foundation, as well as other contributions from UT Southwestern and the Health and Human Services in Dallas County. Oops, okay, going too far. So it should come to no surprise to any of you that there is a shortage of OBGYNs in Texas. There are about 10% of the Dallas counties that have no OBGYNs whatsoever. There is, as of about 2024, the March of Dimes suspects that we will have 46.5% of the counties that are considered maternity deserts, meaning there are no OBGYNs in those areas whatsoever. Yes, a shortage of OBGYNs, and it is proposed that by 2030, we will have 15% fewer OBGYNs than we actually need within the state of within the state of Texas, and thereby compounding the problem that we already have. So this is due to the aging population and the overwhelming demand for OBGYNs, especially in the more rural, underserved areas. So this begins the story of our experience at UT Southwestern and Parkland Hospital. Excuse me. So we start to see that in 2017, a report comes out that sort of starts to pivot what we thought was going on in terms of maternal mortality. This study or this information comes from the literature and a project from the CDC that's showing that there's starting to be a change in the bad actors of maternal mortality. So it's shifting from the issues of hemorrhage, hypertensive disorders, and thromboembolic events more towards cardiovascular disease and pre-existing chronic disease. And so with that, there had to be a pivot in how we're treating these patients. We also saw that there was a strange distribution in terms of the ages of the patients as well as the complexities of what the other causative agents are. So it's not just the disease processes, it's the overall environments of the patients that has begun to change. So this prompted a national response in terms of this huge crisis. So the information was gathered up by the lay press, and it got to be a true global crisis that was recognized by everybody. So that led to the recognition that there have been ongoing challenges with actually collecting the data. So if we don't have the right information to act on, then we can't do what needs to be done in terms of improving maternal mortality. It was reported that up to the past 25 years, there was no decline in the maternal mortality rates, and so something needed to be done. It was discovered that regionalization of maternal care was a good idea, that we should, in terms of providing care, have the highest risk patients with the people who have the most expertise and the most resources in an effort to not only improve maternal care, but also to unburden some of the smaller areas to allow them to do what they needed to do for the uncomplicated patients. We also felt like the patients would benefit from collaborations in terms of what we're doing for patients, much like this gathering today, to bring about awareness of the innovations in terms of what we can do for patients to improve maternal mortality. One thing we're really big on in our hospital is the huddle for the complex cases. Every complex case we do, even some of the uncomplex cases we do, we bring together a huddle with anesthesia, the patient, the nurse, the surgical team, any other consultants, and we go through everything that might be expected and also things that could be unexpected in an effort to anticipate what we might need in terms of special equipment, medications, et cetera. We are really big on simulation as well. Simulation comes about where the idea of practice makes perfect. So on any given week, we have a multidisciplinary team again. It could be in the main labor and delivery unit. It can be in your triage unit, wherever you feel like there's a need to evaluate where the weaknesses are in your system in terms of, does it take too long for anesthesia to show up? Is your staffing appropriate? Do you have the medications? Is there anything else that stands out for this patient that we need to get beforehand instead of waiting until we're behind the 8 ball? And then from a federal level, there was various legislations that came about to help mitigate the maternal mortality crisis. This brings us to the 2018 legislation that served to enhance the care for maternal cases. This legislation set together a framework by which maternal mortality can be addressed via the CDC and trickle down to the local areas and thereby improve it from federal, state, local, and also a global standpoint. And here, I don't know if you can see it, there's a little picture here down in the panel where one of Texas's own is at the Senate meetings to discuss what's going on with maternal mortality within Texas itself. I don't know if you can see it, but there's a Dr. David Nelson there with the blue suit and the blue tie on, who is discussing our various needs here in Texas, not just in the country itself. So one of the outcomes of the legislation in 2018 was the idea of maternal mortality review committees at the state level. These committees were designed to review and study the individual cases of maternal mortality, to do accurate assessments of the actual data, and to make recommendations to actually improve our outcomes for these patients. So it takes it from just being a federal mandate to, okay, we have to do something, bringing it down to the local levels and giving, excuse me, giving the local providers the idea of what needs to be done in their specific areas. This slide is, I actually wanted to leave it out, but it brings out a good point. So even though there was a federal mandate, there also came about other findings that every state was not in the same place in terms of utilization and even establishment of their review committees. So if you look here, you'll see that Texas falls sort of right in the middle. We have our committees activated. We've had the legislation in place, but there's a large representative area that's not there, and those are the rural counties within the Texas area. So you can see the difference between somewhere like California, where they have established committees and are just right out there, right on the front lines, versus some of the other areas that have the hash marks on them, like somewhere like North and South Dakota, that are highly rural and hadn't even begun to develop some of their committees to review the data. So you see here on this next slide, starting in 2018, information became available that showed that maternal mortality was not necessarily occurring where we thought it would. So we provide prenatal and postnatal care, or postpartum care that is, for 6 weeks after delivery. But we found that the majority of the patients were dying from 43 days and beyond. And so that led us to start to think outside of the box. Like, what do we need to do within that time frame to keep the patients healthy? Because the majority of the time, these patients are only seeing their OBGYN maybe for a postpartum visit. They're busy, they're tired, and unless they become acutely ill, they're not going to go to their doctor. And besides that, most of these patients are going to go to their OBGYN for their care in general, because after all, we do provide primary care. And so that was a big thing that brought about our program. So next in 2020, we saw that these numbers were actually a little bit worse, as opposed to the postpartum deaths being in the range of 62%, they were more like 71%, so it was actually getting worse. And so we began to see that it's not the usual bad actors of hemorrhage, hypertension associated with pregnancy and an infection. It was more cardiovascular disease and as well as mental disorders, which tend to be overlooked in our populations. And in addition, if you look at the slide with the various hues of blue here, you can see that even though the issues that we mentioned, such as preeclampsia, eclampsia, and that sort of thing, they are still occurring, and we have sort of a handle on some of that. But then if you look further, you'll see the darker blue and almost the navy blue, with the majority of those deaths occurring from 42 days up to 1 year. It was further elucidated that in reviewing the maternal deaths within Texas, it was found that, oddly enough, a huge majority of these cases were preventable from some aspect. And if you look down at the little legend in the red box at the bottom, it was shown that if you look at the disease entities other than the usual bad actors of hemorrhage, eclampsia, preeclampsia, and the like, there was some chance or a good chance that we could have prevented some of these outcomes if there had been an increased access and the system hadn't been overburdened. And so if we took a look at 36 other states in the area, we found that some of the issues weren't the underrepresentation or the underservice within the rural areas. We found that 82% of the deaths occurred in urban counties. And still, it's not that there's not any OBGYNs, they're not necessarily deserts per se, but the systems are just overburdened with underinsured, uninsured, homeless, older patients. And that's where this mortality is coming out from. And again, you see, if you look at the smaller rectangle at the bottom, you see that again from that review of those 36 states outside of Texas, that 84.2% of these deaths were considered preventable, and that 65% of these deaths were occurring after delivery. So further information that was gathered from the mortality review committees in 2024, one of the first things we found that was 42% of the deaths that were deemed pregnancy associated, meaning that the person was pregnant when they had the condition, these were more than likely cases that were pregnancy related, that may not have happened or been as bad if the patient was not pregnant. And also, again, in 2024, we found that most of the pregnancy-related deaths were preventable at 80%. Further findings in 2024 from the review committees revealed that there was a complex interaction between the contributors of maternal death. So it's not that, okay, this person has a family history of preeclampsia, or this person has a family history of a coagulopathy or whatever have you. It turns out that there are other issues involved, and it shouldn't be a new idea to the majority of the people in this room that, you know, patients don't live in a box. And once they go home from the hospital or from their clinic visit, other players come into action. So does this person have a ride to the hospital? If they have a ride to the hospital, do they have to take the bus to the hospital, and thereby their appointment takes longer? If they get to the appointment, can they fill the prescription that they get when they get there? If they can fill the prescription, what are they going to have to give up in the meantime? Do you get the prescription or do you get food? Do you have another toddler? You get the prescription or do you get diapers? So it's a complex interplay between what's affecting these patients' mortality. And also the disparities that everybody should be well aware of, they persisted and they actually got worse from that previous slide that delineated mortality from the late 80s to the early 2010s. It's actually still gotten worse. So, and it's not just the 3.3%, the 3.3 ratio between non-Hispanic blacks and non-Hispanic whites, but it's also the disparity that exists between the older patients and the patients who have a lesser amount of education, who are still being affected disproportionately. So these committee findings from 2024 also pushed us to be able to target the other quote-unquote special populations that also need an additional help. And so in terms of the recommendations that came out from the review at this point, and this is a busy slide, but it pretty much says what we have already said and what we've known before, that we need to make sure that there's access available, that the resources are prioritized for the patients who need them, that Black communities and other communities that have disparate care are targeted, that there needs to be statewide implementation such that we're not doing cowboy medicine where in one area we're giving, let's say, for example, magnesium sulfate for 24 hours for only the severe, and another area we're doing something else different. We also kind of all need to be on the same page in terms of standardization for treatment care, for treatment for these patients. We also found that behavioral health has to be addressed for these patients. Otherwise, they're going to be extremely bad outcomes, and the overall impetus to care won't be there. We have to address violence. We have to address the actual communities where the patients live. Are they in supportive communities where there are outside resources beyond their homes? And we need to use evidence-based medicine. I know when I was a resident, which was just a couple of years ago, it was more anecdotal medicine. So you had this attending that you loved. You felt like that attending was like the genius that you knew they were. Their anecdotes were what you sort of lived by. And then things have pivoted. You just can't say, oh, I had a case back in 1993 where a patient had preeclampsia and I felt like I could give her MAG for 5 days and hope she did well and blah, 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 because you just can't work like that. It has to be evidence-based medicine. And then we need to improve and expand postpartum care, which is what I'm going to talk about in a minute. And we need to prioritize educating the patient population and continue to improve on what we've done before. And this slide only is included just to show that it's not just a local phenomenon, but there is a fourth trimester that needs to be addressed. And that's that point from that 43 days into that next year. And so going back a little bit, so in 2019, Parkland Health and the local Department of Health decided to do a community health needs assessment just to see what particular areas needed to be targeted as well as what we needed to do within those areas. So the primary things that they came up with and the ideas of attack were to, number one, enhance access to care, address the health disparities, include care for patients with chronic conditions, infectious diseases, and other special populations who are underserved and need particularly special care. And so from that, it also emerged that we need to provide special care not only for the African-American patient who has, disproportionately bad outcomes, or the Native Americans or the Pacific Islanders or whatever have you, but also the LGBTQIA+ community. So that being said, they also took a look at the all-cause mortality rate within Dallas County and found that within this little purple triangle, that was the area that there was the most concentrated, very high mortality rate beyond what was found within the Parkland patient population. And also, this was the area where the patients needed the most help on the issues outside of just their medical care in terms of their social determinants of health. And so even though we like to tout that for our prenatal patients at Parkland Hospital, we have 96% of the patients who present for prenatal care. That might range from anything from 1 visit to 13 visits. But we found that even within the area where patients were supposed to be particularly vulnerable, there was still a subset of patients who still had no access to care and had worse outcomes. And so if you can see the difference between the purple and the green for the areas where people had prenatal care and the areas where they had no prenatal care. And then it showed that the consequences of the patients who had no prenatal care, as we expected, had worse outcomes. And so this slide just shows a picture of where our outreach clinics are. We have 10 outreach clinics within the Dallas County area. But if you look at the southernmost area down where it says, at the lower part of the square where it says Duncanville, Hutchins, Cedar Hill, DeSoto, and Lancaster, that's a huge area where there's only one clinic to take care of several tens of thousands of patients, and the clinic is being overburdened. And so if you go further, you start to bring all of this information together, knowing that from 2012 to 2015, 62% of the patients who had maternal mortalities, those deaths occurred within the postpartum period. You see that non-Hispanic Blacks are disproportionately affected. You see the area where the clinics are distributed versus the area where in the purple triangle versus the purple rectangle, where the highest mortality rate is. And then the input from the community health needs analysis was carried out. That brings us to what we needed to do to really drill down and find our target area. You see that within that little blue blob there, that there are 2 clinics that are somewhat close, but the southernmost clinic that's identified, again, has to care for all of those areas that are adjacent to it and beyond. And again, that clinic is being overburdened. And so CHNA, the CHNA target region was identified, and it showed that, again, even in the most vulnerable areas, the perinatal outcomes were significantly worse within this population, even if you matched for age, race, parity, number of prenatal visits, and pre-existing conditions, including chronic hypertension and diabetes. Even with all of that, these patients still within this area had worse outcomes overall. Not anecdotal, but done by the science. And so this one further elucidates that within that target region, there is a high number of non-Hispanic Black patients who, even though within a vulnerable community, this subset of patients still, even with age matched for gestation, blah, 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 they still all had worse outcomes than the patients who were adjacent to them. And again, it's a complex interplay between social needs, medical history, community burden, community outreach, et cetera. So once we started to digest all of this information, of course, the pandemic occurred and it sort of overlapped what we needed to do. So one thing we did at that point was we had an issue with access to contraception. So in light of the fact that we could not do postpartum tubal sterilization on our patients, we had to pivot yet again. And we received a grant whereby we can provide post-placental IUDs to every patient who delivered at that time. We attempted a study at that point that showed that the patients were really receptive to receiving those IUDs. However, at a point, again, we were sort of overburdened because we lost some of our ORs, we lost some of our equipment and blah, 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 just because the COVID patients were taken over. But another thing that came out was that the patients also, in terms of enhancing access for their postpartum visits and their prenatal visits, they readily accepted virtual visits, thinking outside of the box to a certain extent. And so other areas were doing the same thing. There was an article in JAMA that showed that audio-only visits versus in-person visits, there were no differences in the perinatal outcomes. Patients did just as well and readily appreciated the idea that somebody was still checking up on them in spite of the fact that they couldn't actually see a provider in person. And then we did another study of our own in-house where, in an effort to enhance access for prenatal as well as postpartum care, we gave patients audio-only visits, and 95% of those patients readily accepted the option to come in, and the outcomes were just as good. And I'm going to skip that one. So putting all of this information together in terms of what's going on with the maternal mortality crisis at a global level, what's happening in terms of federal mandates, and what's happening at our local level, we came up with a plan that said, okay, first thing we did was to define our target region. We checked what our baseline measures were just to see how much of an effect we were having after the program was implemented. We decided to enroll the patient at discharge and establish community partnerships so that they were already within the system and they didn't have to be contacted after they left. We provided physical care using a mobile unit with providers that went out into the community as opposed to the patients having to come to the hospital. We did serial telehealth encounters as well as follow-up with nurses and mental health counselors, and we subsequently measured the outcomes of the program thereafter. And so this brings about our program MCAP, Extending Maternal Care After Pregnancy. So in terms of how we devised the system, again, we identified patients within the community that, we identified the patients in the community that needed to be enrolled, assessed their social determinants of health, and they were either virtually or in person visited by a home nurse and then followed up at 1, 3, 6, and 12, 9, and 12 months with either virtual visits or the mobile health unit going out to them. Here's some pictures of some of our patients who had been approached, and we did the enrollment postpartum on the mother-baby unit. We set up an electronic identifying database so that we could target the patients within the zip codes. We had patients who were Spanish-speaking only, and so we had a bilingual staff, and we made sure that our patients were culturally and linguistically trained to serve those patients that needed special treatment in terms of language issues. Our enrollment goal was 70% of the patients who were eligible, and we exceeded that from the beginning up until 2024. This is a picture of our enrollment form where we address not only the medical history, but some of their social determinants of health. This is a picture of our electronic registry where we had a real-time dashboard where we can follow up with the patients. And then in terms of social determinants of health, we looked at everything from clothing to babies, diapers, housing, rent, to see where the patients needed the most help, as well as in terms of transportation, which was a big thing, and some patients who didn't even have Wi-Fi. Skip that. Okay, so here's a picture of our mobile health unit. It was a multidisciplinary effort. We used nurses, nurse home visitors, physicians, advanced practice practitioners, community health service workers, social services, behavioral health teams, and a pharmacist who all went out at the same time on that mobile health unit directly into the community. We won several awards, blah, blah, blah. We're great at what we do, blah, blah, blah. I'm sorry, I'm running over. So after that, we went into a technology-enhanced extending maternal care after pregnancy. So this was an audio-only platform where we The patients were assessed, they were offered a home visit at the beginning, and then they were followed up by phone calls. Again, our rate of enrollment was supposed to be at 70%. We exceeded that. We started this in 2024. So far, everything's going great. However, some of the barriers come up as of late where people don't necessarily want to go to a big mystery van with the expectation that you're going to receive prenatal care. And oops, ice drops out. So that sort of shifted our numbers a little bit, but they're still doing okay. And then after that, we're extending into other areas with some of the rural representation out into Hunt County. And that area, they have only one hospital, and their emergency room just closed after I made these. So we're going out there with a brand new mobile health unit that we were able to get. With grant funding. So it's the sole hospital in that county. They have a shortage of everything. They used to have 900 ED visits for STI treatment, so all of those patients are in the breeze, so we're going out to address that. And this is a picture of the mobile health unit. We plan to offer on the new unit family planning, management of medical comorbidities and mental health issues, as well as screening and management of STIs. I'm going over time. We'll do 2 days out in that community and 1 day out in another community and 2 days out in a separate community. Again, checking enrollment, blood pressure, mental health, STI, among others. And it's a complex situation. We need accurate data, and we need to know that we're transitioning from that classic triad of hemorrhage, blah, 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 and that the effect of postpartum care up to a year gives us the time to not only take care of the patient, but also to transition them to a PCP. And here we are. Thank you. Sorry I went over time.
Question on the telephonic and televisits, where you saw good patient engagement, they liked it, but some of the things we noticed in COVID when we went to a lot of virtual visits is we actually saw worsening of diabetes and hypertension in some of our populations. And so I'm just wondering, on the outcomes piece, we still missing something, or how are you marrying that with some in-person visits? You know, obviously you've got to, do your 20-week ultrasounds, you've got to do blood pressure measurements potentially in the office. I know they can be done at home as well. Just wondering how you're mixing these telephonic visits with what you need to do in an office setting.
So one thing we do in terms of the diabetics, we offer them inpatient surveillance starting at 34 weeks. And so they're admitted at that point, and their NSTs, as well as their blood sugar, hemoglobin A1Cs, et cetera, are monitored from that standpoint. From the standpoint of the blood pressures, we got another grant whereby we give every patient who has hypertension a blood pressure cuff, and they're actually given education in-house before they're discharged. And then they check their blood pressures at least twice a day. And if there's issues, they call in, and then they're instructed as to whether or not they need to come in for further evaluation. So there's still like those stopgaps in place to educate patients on when they need to come in, but it just gives the patients who may not have as much of an acute issue the opportunities to still be followed without having to expose themselves when they came in.
Thank you. Another question? Yes. Go ahead, if you don't mind standing in the mic, right in the middle.
Thank you. That was really beautiful, and what an inspirational amount of work you guys have done towards this. I was actually sort of curious. I think that COVID was a bit of a gift to us to figure out how to set up telehealth systems and to build compensation into those systems so that we know how to bill for those. But in this model where you're doing this beautiful project, I was curious whether it ended up being, is it sustainable with billing? Can you get compensated for it, or is it all volunteer and grant supported? But please help teach, because we should all have such systems. Thank you.
Thank you for your question. We actually had a team that was dedicated to building a dashboard such that when the patients came in and got any sort of extra care beyond that magic 6 weeks, that we were compensated to a certain extent. It wasn't a huge amount, but it did pick up the slack to where for where some of the grant funding and private charitable donations dropped off. So it's not completely gratis.
Good morning. Thank you very much for your wonderful presentation. My name is Dr. Doche. My question have to do with the trackable devices and the wearables. Were you able to use any of those with any of the postpartum patients, or are you planning on doing that, or have you seen any features with that? I'd like to hear more from you on that topic, please.
We weren't using any trackable devices per se yet, but and I couldn't get to it on the slides, but there's an expansion beyond what we've done with MCAP and tele-MCAP and Hunt County, whereby we received another grant to study the technology-enhanced postpartum visits beyond just using the phone. So it's in the process, but it hadn't come to full fruition yet. But yes, that's in the works.
Did you see an increase or an acceptance from the community stakeholders, and were there any issues or any challenges with their receptiveness to the program or their participation?
We did have a very positive response from some of the stakeholders. However, us being a state entity, some of the collaborations that we wanted to do weren't possible after a certain year with certain political changes. So we lost some of those partnerships that were geared toward purely maternal mortality and affecting infant mortality rates. But there were some topics that they wanted to offer through Planned Parenthood and other agencies that us, being state entities, were not able to do. So we lost some of the collaboration from that standpoint. But from other standpoints, in terms of, there's one, the Hope Supply Company, they supply us with diapers, among other things, and we are able to distribute close to 80,000 diapers per month, as well as a collaboration with a local food bank and some of the others. So I think overall, the response was pretty positive. But we made sure to, before the MCAP and tele-MCAP were even rolled out, that we had input from the people within the communities that we were trying to go to, so that we could build that trust thing and that intimacy thing so that we all were on the same page.